Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm delighted to be joined by two guests, Sue Down, who is the consultant lead in breast surgery, and her physician associate, Laura Smith. Welcome to the show, both.
Hello.
Thank you, James.
Thanks so much for joining me on the Physician Associate Podcast. I wanted to get you on to talk about how you're deploying physician associates in your workforce in breast surgery and the impact that it's having on the service. I guess my first question might be to you, Sue. What was the thinking behind recruiting a physician associate?
Well, thank you for having us on, James. We work in a very busy district general hospital, and we have seen numbers of referrals for breast problems increasing exponentially over the years, with the resultant fact that we need a lot more capacity in our clinics, operating theatres, follow-ups, etc. We were finding that the traditional workforce model wasn't really addressing these needs. We have now 4 consultant breast surgeons working in our unit, but what we don't have really is any middle grades. There's a lack of trainees and non-training grades associated with our breast service. As part of the training, they needed to get experience on the wards. And because of this, the trainees weren't really being assigned to the breast service. We also have a slightly different model to other surgical specialties in that most of our work is carried out either in the clinics and in daycare theatres. So we have very little inpatient ward presence. So we felt that we had a real need in the kind of middle area between the very juniors and the consultants in our breast service. And that's where we thought the role of a physician's associate would come in most useful for our service.
And you'd been having physician associate students from the local university programme into your department as well, is that true?
Yeah. Well, I run some postgraduate courses at the University of East Anglia, and obviously there's an established PA programme there run by Audrey Gibbs, who I know well. And we have had PA students assigned to our unit for several years now. And when we had our PA students in the clinics and theatres, we always found them very engaged, very focused and very interested, which is very fabulous, really, when you're training or teaching.
Brilliant. And Laura, you were one of those UEA physician associate students, weren't you? Did you spend time on the breast unit as a student?
Yes, I did. So I had my surgery module at the hospital, and I was lucky enough to have a clinic and also a theatre session with the breast surgery team.
And is that experience what led you on to thinking about working as a breast surgery PA?
Definitely. I really enjoyed my student placement with the breast surgery team, and definitely when I saw this job advertised, I was very excited to apply, and everyone was really friendly and welcoming as a student, which I think really makes a difference when you go on to apply for a job wanting to work for a department.
So Sue, when you were considering making this business case to employ a physician associate, sometimes some of the stumbling blocks or the hurdles that we hear about are the lack of regulation or the lack of prescribing rights for physician associates. Was it particularly a hard sell to your business managers and consultant colleagues to take on a PA? And how did you overcome any of those problems?
It wasn't a hard sell at all to be able to obtain funding for a physician associate post. We were able to demonstrate the service needs and the lack of staffing at that level and the benefits that a PA would bring to the service in terms of continuity of care, availability for the patients, improving the patient cancer journey. And Laura has been fabulous and really has justified all of our claims that we made to our managers and beyond. So no, we didn't have any issues whatsoever. The funding actually for Laura's post came from what would have been the middle grade posts for our service. So that's how we were able to fund Laura's post. Day
to day, does a lack of regulation or a lack of prescribing rights have much of an impact on your job? Is that much of an issue for you as a consultant, Sue?
No, it hasn't been at all for us, mainly because we don't do a lot of prescribing in our role. And all the prescribing that is done on pro formas and done by ourselves and the anaesthetists really in theatre. So there's no real need for Laura to have to prescribe. The only time is in wound clinic if she has a issue there where someone needs antibiotics, and we always make sure that there's somebody around in the service and she's not left on her own. And if there wasn't anyone available, then we can send out prescriptions later on. So it hasn't impacted the service, I don't think. But Laura might give a clearer answer on that. She might have been in a position where she wanted to prescribe and hasn't been able to. I'd hope that generally we've been able to support her for that.
Yes, I agree. There's always a consultant around to support me, whether I'm in wound check clinic or in a new patient clinic where a mammogram needs to be arranged, because obviously PAs cannot organise those. So I haven't had any problems at all with those restrictions.
Was there any consideration given to other roles like advanced nurse practitioners, or was it a physician associate that you chose for a specific reason?
So we already have specialist clinical nurses working within our unit, obviously, and there aren't any nurses in theatre who would be suitable to be trained up as advanced nurse practitioners because of theatre staffing shortages. So they're needed across the specialties rather than just in one specialty. So this is why we felt we wanted a PA because they could have a variety of roles and were much more flexible than actually having someone like an AMP who was probably going to be a lot more fixed in what they were able to do or maybe willing to do. So that's why we chose the PA role.
And there's something to be said for the sort of medical model style of training, isn't there, that means physician associates can slot into your team and think in the same sort of ways as doctors and are familiar to the established medical team there already.
Yes, exactly. We've Laura brought with her a good understanding of the structure of the medical team. Although, the medical team is not as it once traditionally was with consultant, registrar, senior house officer, etc. Now it is much more fluid, which I think is a good thing. And you have to move with the times. And as staffing changes, you need to be willing to adapt and to be flexible as a team, I think.
So, Laura, if I come to you next, what does a day as a physician associate in breast surgery look like?
So, as Sue said, my job's very flexible. So about 50% of my time is spent in theatres, so assisting the surgeon. And then the other 50% of the time I undertake new patient clinics where I assess new patients and formulate management plans. I also do a wound check clinic alongside the results clinic on a Wednesday afternoon, and that's to check kind of post-op patients, to remove their dressing, to check they're doing okay and dealing with any complications after their surgery. I also am currently triaging all the GP referrals that come in online and kind of allocating them through to the clinics. And also, especially with breast surgery, there's a lot of quality improvement and research going on. So I have an active role in that as well.
One of the areas that Laura's really been helpful in is the interventional areas that are maybe beyond the training of the breast care nurses, but that the consultants maybe don't have the time to do. Things like seroma drainage, which can be a really big part of managing post-operative patients in breast surgery. And she's learnt very, very quickly, I have to say, the techniques of safe seroma drainage aseptically. And that's been a real benefit to the service and the patients, because it's been able to alleviate any discomfort, and they haven't been had to wait around for one of us to be free to do it. That can involve an hour lying on a couch. So there's other skills that she's managed to bring to the service, which I think other disciplines such as AHP maybe wouldn't be able to provide. So it comes back to the flexibility of her role and her being able to grow into it and respond to the shifting needs of the service, really.
And what skills did you have out of university that you were able to use directly in your role in breast surgery? And I guess what skills have you had to learn that are specific to your job now?
So I think physician associates are taught a very broad-based skill set. So then we can go into several different roles, whether it's primary care or surgery or medicine. So I think the generalist knowledge that I had helped me come into this role. Also, I think communication is hugely important in breast surgery and with breast cancer patients. So learning that at university has helped a great deal. In terms of what I've had to learn, we don't really get much breast teaching in a university because we're having to learn so much in those 2 years. We didn't get a great deal of teaching. We had a kind of broad overview. So I've had to learn pretty much the whole of breast disease and breast cancer, and also all the surgical skills that comes along with surgery.
So when Laura came to us, obviously she came with the general basic knowledge, as she said, and then we had to look at the areas that she was interested in, that we needed her in as well. And we sat down and we created a introductory plan for her, which ran over 8 weeks. So introduced her to all aspects of the service. So she spent time with breast secretaries, breast radiology, theatres, breast imaging. So there's all these different areas we work with. We were hoping she could spend some time with pathology as well to see how the specimens are dealt with. But because of COVID, that hasn't happened yet, but that's due to happen as well. And that gave her a broad overview and understanding of how everything worked together before she started in her role. And we started out with her shadowing us mainly, attending theatres. And as time has gone on, obviously she's picked up the skills needed and she's been able to expand her role into the areas that she's interested in, but also that we've needed. So we found in the last 6 months with COVID that we've had particular issues with pathology taking longer to report because of staffing issues. And due to that, that's why the wound clinic was introduced, so that patients could be checked before their results were available. And that wasn't needed before. So that's a new innovation that Laura's been able to help us push through. Similarly, with the triaging of the GP referrals, prior to the pandemic, the number of referrals allowed us to offer a one-stop clinic to everybody who came in. We weren't selective about who attended that. Now our referral rate has doubled since the pandemic. So we have to be able to focus our resources as to where they're needed the most. So when our radiologist is available, we want them to be seeing higher risk patients. And that's why Laura has been able to implement a triage algorithm, which she's audited and found to be safe, making sure that we can identify the highest risk patients who can be brought to the one-stop clinic and the lower risk patients who can be assessed clinically and then have delayed imaging if necessary. And she herself, as she said, runs some of those clinics as well. So that's how we've started the first year. And she's now completed a whole year with us. So we're due to have an appraisal of her job plan and see where we're going to go for the next year. But our plan really is that she's becoming more and more independent and she'll be able to run her own one-stop clinics by the end of next year. I'd have thought maybe even some minor ophthalmists herself as well.
Sounds cool. How exciting. Yeah, one of the questions I was going to ask is, how do you do effective supervision and what have you found useful as a PA yourself, Laura? And how does that look similar or different to what you provide for your trainee doctors? And
I think one of the issues I did have at the beginning is because we'd never had a PA on our team, trying to find some information and support as a supervisor as to what was expected of us. And there are very few courses available for PA supervisors to attend, and very little information directing us as to what we should be doing. So we liaised with the trust mainly and followed the internal trust appraisal processes, and that's what we've done. And it does mirror the trainees. So when I'm educational supervisor for junior core trainees, it's a very similar process, and that's what we have been following. But I think it would be helpful if there were more courses available specifically for PA supervisors and supervision, and more resources available that were quite easy to access online.
Laura, when you started as a PA in breast surgery, what resources and teaching and courses did you find useful that you would share and recommend to other PAs who might be at the start of a breast surgery job?
So I think my main teaching came from my consultant colleagues. I sat in lots of clinics, kind of new patient clinics and results clinics, and they have spent a lot of time with me kind of teaching and giving up their time to do that. So I think that was where my main kind of knowledge base has come from, is my colleagues. In terms of online resources, I actually used the e-learning for healthcare modules. There's a lot of different modules on breast disease and breast cancer and breast imaging on there. So I've gone through all those as kind of during my first year.
And Laura has also piloted our new online breast care nursing module, which is actually designed for breast care nurses, but there's a lot of overlap in terms of the teaching. And that's going to be available later this year for breast care nurses in the UK and abroad. So that is another useful resource.
I guess, Laura, the next question I was thinking about is, what are the really good bits about being a breast PA? What's the most rewarding parts of the job?
The most fulfilling part of the job is that being with breast kind of 100% of the time, I can really see the patient process and their journey. So I get to meet patients and get to know them quite well. And I think that's really important as part of also job satisfaction, that you don't just see a lot of these patients once, you see them multiple times, and you're able to support them through their breast cancer diagnosis and management. I think that's really rewarding as a healthcare professional.
And that's important, as physician associates don't rotate like junior trainees would rotate on and off services and departments. It's nice, I guess, that you offer that long-term continuity over months and years to look after your patients
Definitely.
and their families.
To be honest, I've had such a great year. I haven't had any bad moments. It's been really good, and I've learned so much, and I'm really enjoying my role. I think the only thing is that there's only me in surgery in the whole of the hospital, so I'm kind of on my own, and I do hope there'd be some more physician associates joining the trust in the surgical specialities.
Thank you, guys. Thanks for explaining all about your job and how things work. Where do you see physician associate in breast surgery developing? Are there new skills that you can acquire, new responsibilities? How do you think that's going to evolve over time?
So I'm coming up to my kind of 1 year appraisal. So the good thing about my role in breast surgery is that I am so flexible. So a lot of it is kind of where the service needs me, and the service development and things. So I think I would like to maybe become a bit more independent in clinics and taking clinical decisions. But that all comes with experience.
I think you're right, Laura. It does come with experience, doesn't it? So It's knowing which areas that you're comfortable in and which areas you still need to expand in, and which areas you're interested in, which I think is the most important thing, isn't it? Because I think one of the things that we said at the very beginning with PAs was that you can just get shoehorned into a job that's exactly the same day in, day out, without progression or anything else. And what we're really keen to do is make sure Laura feels like she's progressing and increasing her skills and staying interested and being challenged, in her role, so that she is able to progress. And I would see that in a couple of years' time, maybe we are able to employ a second breast PA who's junior to Laura, who Laura would then mentor, and be able to, even if they're only in a temporary role in our service, then they could go out to another breast service and be trained with us and then move on to another role permanently in another unit. So it's possible we could end up as a training unit for breast PAs led by Laura in the future. But that'd be more of a 5-year plan, Laura, so don't worry. Laura's going to be presenting a poster at the National Conference for Breast Surgery about her role in our unit and the role in triaging patients and resource management. And I think that will place the role of PAs in breast surgery more in a spotlight for the UK. So I do see it. I see a massive role for PAs in the future. People are coming out of science degrees, the undergraduates who are graduating, because that's the group of people we're really interested in promoting and recruiting, isn't it? And I think more could be done at almost undergraduate level, if you like, to promote the role of a PA, rather than waiting until postgraduate level and people being recruited later on.
Definitely. Because I first heard about the role as in a careers session in my undergraduate degree. I had never heard of it before then, and it was mentioned quite briefly then, and I looked into it, and that's how I kind of came to found the role, because it's quite a big investment postgraduately for 2 years and with quite little funding. So I have been really lucky that there's lots of employment after graduating. So I think that's a guarantee that some people maybe are hesitant that there's not enough jobs out there afterwards, after you qualify.
In my experience, supply of physician associate graduates is not meeting the demand that is now growing in recruitment for the profession. So thanks so much, Laura and Sue, for joining me on the podcast today. If people have been listening to this and it's sparked off ideas or questions that they might have about physician associates in breast surgery, would you be happy for them to get in contact with you? Where would you point them to go to find out more?
Yes, of course. I mean, I'm always happy to answer any questions that anyone has about my role and whether they're interested in breast surgery.
And I'd be more than happy to share any business plans that we developed and the job plan role documents that we developed for Laura's role with anyone who's interested. And I can be contacted via my James Padgett email, which is available online.
Perfect, thank you. I'll leave links to your contact details on the episode notes of this episode so people can find it on their device there. Thank you so much for joining me.
Thank you for having me.
Having us.
And thank you for listening as well. I hope you found that really interesting to find out more about physician associates in breast surgery. If you'd like to get in contact with me, I'm on social media at PA Podcast UK, and it'd be great to hear from you about what you're doing as a physician associate up and down the country. If you've got any ideas for future episodes or people that we should be speaking to, do let me know. And I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.